Well, greetings everyone, and welcome to the EKG case for the week of September 15th, 2014. This is Amal Mattu at University of Maryland, and this is a very special week, actually, as we start the beginning of our fourth year. Unbelievable that we've been at this for 4 years now. That's 156, approximately, consecutive episodes, and we are still nowhere close to running out of things to talk about with electrocardiography. And over the past 3 years, I know I've learned an awful lot from the cases that you all have sent me. I've had to look up a lot of stuff in trying to figure out some of the answers, and I hope you all have been learning from what we've been talking about and learning from each other as well. So keep those cases coming. It's been, I think, a great benefit to everybody, most definitely to me as well. Well, we're going to keep it short and sweet this week so that we can get on to eating our cake, right? And this is a nice quick case that was sent probably over a year ago by Dr. Jim Villarreal, who works in Salt Lake City, Utah. And he nailed the diagnosis, even though the EKG machine completely got it wrong here. He was taking care of a 67-year-old woman who presented to the emergency department with a 2-week history of dyspnea on exertion. She's got no chest pain or cough, and her exam was really just notable for a mild tachypnea. She wasn't in respiratory distress, but she was breathing pretty quickly, and there was nothing jumping out at him on the 12-lead EKG, or rather on the physical exam. But on getting the 12-lead EKG, there was something that did jump out at him. The EKG machine, of course, looked at this, and the EKG machine called this inferior, let me get rid of this for a second, inferior ischemia, and also anterior wall ischemia. There's flipped T waves all over the place. And one of the things we've said before is that when you see flipped T waves, you should not always just automatically assume that T wave inversions equal cardiac ischemia. That's what I learned. That's what a lot of people learn. It's wrong. T wave inversions are common in a lot of conditions, and maybe one week we'll come up with a list of probably 50 things that can flip your T waves. But in addition to cardiac ischemia, the other major organ system that is notorious for flipping the T's is the pulmonary system, the lungs. Lung problems can cause flipped T waves. Acute lung problems, for example, pulmonary embolism or pneumonia, or even a hyperventilation. Hey, if you want to have a little fun during one of your shifts, hook yourself up to a 12-lead EKG and then just start hyperventilating, and you will notice your T waves, in many people, your T waves will flip. You may then pass out. So maybe it's not such a good idea. And if you do that, don't tell anyone that I told you to do it. Probably, you know what, just delete the last 30 seconds or so. Not a good idea. But maybe you can suggest it to one of your colleagues. But definitely don't do it if you're single coverage. Gosh, that would be bad news. Anyway, hyperventilation can do it. And chronic problems like COPD and pulmonary hypertension can do it. Well, one of the things that we've talked about is that if you ever notice this combination of T-wave inversions in the inferior and the anteroseptal leads together. Sure, if you have lateral, that adds a little bit more, but really, if it's just inferior and anteroseptal, that's all you need. That is highly specific for pulmonary hypertension. That's something that Marriott, one of the real experts in the history of electrocardiography, he talked about this 3 decades ago at least. When you see flipped T waves in the inferior and anteroseptal leads, that is pulmonary hypertension. And in the emergency department, if those T wave inversions are new, if your patient's symptomatic, new pulmonary hypertension, in other words, acute pulmonary hypertension in the emergency department is what? Of course, it is a large pulmonary embolism. This is a sign of heart strain. There's various theories about why PE can flip your T waves. Some people say that pulmonary embolism induces some subendocardial hypoxia and ischemia. Some people say that when you get some ventricular distension, it shifts the axis of the heart, and that can produce some T-wave inversions. Whatever the reasons are, it's very important to remember that when you have new T-wave inversions, for the third time now, when you have new T-wave inversions in the inferior and anterior septal leads, that is acute pulmonary hypertension, which in emergency medicine is PE. If those are old flip T waves, then it means a person probably has some element of chronic or old pulmonary hypertension. And in our, we've studied this actually and published this in cases that we've looked at when people have new flip T waves in the inferior and anterior septal leads. The diagnosis number 1, 2, and 3 turns out to be pulmonary embolism and not acute ischemia. And Marriott specifically said in his textbooks, whenever you think you're looking at acute inferior anterior septal ischemia, a light bulb should go off in your head. Inferior plus anterior septal ischemia equals pulmonary embolism. All right, so very simple case, and Jim got the diagnosis long before even needing a CAT scan. He looked at that 12-lead EKG and called it a PE right from the start, and then he went ahead and got his confirmatory CT, and it turned out to be a saddle embolus. Fortunately, the patient ended up doing okay. Usually these are relatively large PEs, not the small PEs that you're getting listening to this video cast, or that I'm getting providing the video cast. Not the small PEs that we probably all walk around with. These are generally large PEs. So, simple take-home points. Remember, once again, large PEs are notorious for causing flip T waves, especially in the inferior and anterior septal leads. Anterior septal is probably most common, but when you have anterior septal plus inferior, it turns out that that's very, very predictive that somebody has a PE. And what we in our department have learned is that that's a PE until proven otherwise, and a lot of other people have come to realize that as well. Well, I'm not going to belabor this point. We've talked about this T-wave inversion thing with PE a few other times before, and if you want to get some more cases, just go to our website, www.ekg.umem.org. There it is right there. Go to this website, and you'll come up with all of the different cases. Then just scroll down the left-hand side of this website, and then you'll come to a search feature, and then you can just enter whatever you want. Put pulmonary embolism in there, and you'll come up with a handful of previous cases of PE. These are a couple of relatively recent cases that we've done on PE. April 15th, 2013, June 24th, 2012, if you want a few more cases. But be on the lookout for this. You're going to see it in your practice. If you take care of patients that have PE, you have been seeing this already. You will continue to see it as well. So, simple, quick take-home points there. And my thanks to Jim Villarreal for sending this classic example of a PE. I hope that was helpful. And again, thanks so much for supporting this video cast for 3 years. And I look forward to another great year of electrocardiography fun in store for us. All right? So until next week, take care.
So let's just start with the simple cannulation then. This doesn't look very simple, right? So, but if we take some of these things away, we'll end up with the basic ECMO circuit and machine. So this is the oxygenator, this is the pump, this is the circuit, and what connects all of these to the patient is what? The cannula, right? So the cannula is very, very important because without it you cannot do ECMO. And there are different cannulae. This is the cannula we use for basically, venous access or vascular access. So it's blue in color, as you could see. There are multiple sizes and lengths. And we have the arterial cannula or the return cannula, which is marked in red, as you can see. It's a little smaller because now we are not having suction, okay? And you can use it for the IJ or for the femoral. And as you can you please turn that off? Turn it off, yes. Okay. And as you see, there's some metallic or metal component to the cannula itself, because remember that we are sucking blood at a very high flow, 5 liters, 6 liters per minute. So we don't want this cannula to collapse. And there are sizes that I've mentioned, but normally for veno-venous ECMO, we use 21-23 French for the return cannula, and for the access cannula, 25 usually. 29 is a bit big, but we use it. Now, they can be used for 14 days. They are approved for 14 days, but we can use them for probably up to a month and a half. Okay, so this picture has been shown already by Sultan, and as you see, the way to access the patient's venous system is easier if you use the femoral approach. So femoral is probably easier. And as you see, the venous part of the cannula has to be in the IVC, while the return cannula tip has to be in the right atrium. And the reason for this, as Sultan mentioned, we don't want to have recirculation, right? Sometimes your venous cannula or access cannula is not sufficient to, get the enough flow you want, so you may have to add another cannula and connect them both with the Y connector. Probably Salim will talk about that even more. Sultan alluded to the double lumen cannulae, and this is called the Avalon catheter. And as you see, it has two lumina, and they are similar to the the dialysis catheter, if you see, but they are a little different, or a lot bigger and much more complicated. You'll see that. So if you compare this to that, you'll see the difference now. So this cannula enters into the IJ, going all the way down to the IVC through the right atrium. And if you see it here, you'll notice that there are three sets of holes. You have distal holes sucking blood from the IVC into one lumen, proximal holes sucking blood from the SVC into the same lumen. So this is your access or venous lumen. And you have a set of holes in the center of, or in the middle of these two sets of holes, and this is connected to the other lumen, which is the return lumen, and it pushes blood directly towards the tricuspid valve in the right atrium. So in this particular cannula, you have to know exactly where you're putting your cannula. A little noisy. Okay, now with Avalon catheter, for males, usually we use 31 French, females 27 French. It could be variable, but probably Dr. Aziz will talk about that more. And remember, now you have a very long guide wire and multiple set of dilators, okay? And you will see why we need these dilators. They come in different brands, but I like the previous one more. Now, in August of last year, we developed in our unit a set of things that we should do before we start cannulating a patient. The reason for this is that we had several complications related to being unprepared for the cannulation per se. So I'll just go over this quickly. So first of all, we like ourselves to have the family sign a consent, because it has to be high-risk consent because you're dealing with life and death here. The patient has to have refractory hypoxemia that's not responsive to other modes of rescue therapies. Now, this is the checklist. I'm not talking about indications. So before you put your cannula in, you have to make sure that the other things that are less important are already present, like arterial line, central line, fecal management system. If the patient has pleural effusion, don't put it after you put your cannula because you anticoagulate your patient, so put it before that, etc. The other things that you make sure that your patient have enough hemoglobin. And in fact, this is very important, and sometimes we overlook it. Of course, coagulation and platelet count has to be appropriate for cannulation. And in addition to that, you have to keep at least 4 units of packed red cells ready to use at the bedside, or at least in the unit, in the fridge. Now, FFP is debatable. That's why I wrote optional over here. What else? Remember that your patient could bleed, could go into hypotensive crisis. So make sure that you have vasopressors and inotropes prepared and connected to the patient. Not infused, of course. And you have to make sure that your patient's well hydrated. And the reason for this is that you want the IVC to be dilated so that when you start the ECMO, it will not suck the walls of the IVC and you will go into trouble. And I'll tell you an example that we've had in the past. In addition to that, if you're not sure, give some fluid. You can check the IVC, as I'll talk about in minutes. And keep more fluid available just in case if an emergency happens. Adequate sedation and paralysis, and Dr. Bafaki will talk about that later. And heparin. Sometimes, I remember on one occasion we inserted the guide wires. Where is the heparin? It's not available, so make sure that it's available. And I like a concentration of 100 units per mil, so you'll inject like 2.5 mils to 5 mils after you put your guide wires in. And clip the hair. Many of our patients have big beards. Ultrasound machine has to be available, and I'll talk about that more. And chlorhexidine, of course. And it is preferable that you take your patient to an area where you can manage the patient very well. The OR is the best, especially if you have the C-arm fluoroscope over there, because it will help you guiding your cannula, especially if you are using the double lumen Avalon catheter. Angio suite is not the best, and the worst is the patient's room. And this is unfortunately what we are doing in our unit. Like, you have 20 people in that tiny room, and we had to do once, remember Fahad, to do cannulation in a patient who is on rotaprone. So you have to jump over that arch over there and do it. We couldn't move the patient, we couldn't move the rotaprone, so we had to do it. Now, if you don't have the luxury of having fluoroscopy, you can use TEE for accurate positioning of your cannula tip, especially if you are using Avalon catheter. I personally prefer to examine the patient before I even start anything. I prefer to examine the right IJ. I don't like the left IJ because of the fact that you have this, unhappy course of the left IJ, right? Because you may easily puncture the IJ with the dilator if you go to the left IJ. So the right IJ is the best, right femoral, left femoral. And I also recommend that we examine the IVC. If the IVC is small, it indicates that the patient is not full, so give the patient fluids. Now, I'll just show you examples of how the IJ could be nasty. So this is a very nice, happy IJ, right? It's big, it's easy, but sometimes you get a very small IJ. So imagine that you've cleaned your patient, you had your catheters opened, which costs so much money, and then you looked with the ultrasound and you notice that your IJ is this tiny. So you can't really cannulate that one. So probably examining the patient beforehand is useful. Another case where you have a very abnormal IJ, probably it won't stop me from putting a catheter there, but it is something interesting to see. A small IJ with a thrombus inside it, another small IJ with the thrombus inside it, multiple vessels around it. And so what do you think is wrong with this IJ? This is one of our patients and has a very funny IJ. So what do you think is wrong? So why is this IJ collapsing and dilating? Huh? Yes, excellent. So I'm not applying pressure, and you could see that from the fact that there's no compression of the superficial tissues. This patient is very dry, so examining the IJ also will give you a hint of how hydrated the patient is. This patient was on high pressure, and yet his IJ is dilating and collapsing with breathing. So it's really important to do this thing before you, even decide to cannulate. Subclavians, we don't do it percutaneously. Probably Dr. Aziz will talk about the cut down the technique for the subclavian. He told me about it last night, which is very interesting. So after you made sure that your locations are good, clean, 3 potential locations, and I prefer right IJ, right femoral, left femoral. And the reason for this is that you may fail here, you have another clean area. Apply the eye sheets to these all areas, and then put a full body drape. Okay, if you are in OR, you'll have everything ready. If you are in the ICU, you're in your own. Okay, so now I'm going to show this video and I'll explain to you everything. This is the Avalon catheter. You see how big it is? This is probably 31 French. And then this is the right IJ. The patient's already prepped and prepared, and everything is ready. You see how many people are in that operating room. You have so many people to help you with the ultrasound technique, with the sterile sleeve. You put your needle in, and then once you get the needle in, you pass your guide wire. With fluoroscopy, you try to pass the guide wire so that it passes through the right atrium from the SVC down to the IVC. This is what you want. You don't want the guide wire to loop around in the RA or goes into the RV or the PA. So that's why fluoroscopy or TE is very, very important. This is the set of dilators that you will use, probably 7 for the Avalon catheter. So after you pass your guide wire correctly, you make a reasonably big and deep incision. Not that big, but with cut down, probably it's okay to make it very big. So this is again the percutaneous technique. We are not talking about the surgical cut down. Make sure that the hole you are making is well dilated with the forceps, and then pass your first small dilator. Okay, go in. It's better to lubricate your dilators as well, because this will help. If you have fluoroscopy, you can even see where the dilator is going. And slow and nice rotationary motion is probably necessary as well. And then just go on and on until you get the biggest dilator, which is the last one, and just pass it through, and then you are ready to pass the catheter with its dilator. So there's a dilator in the catheter. You see how long the guide wire is, and then you pass the Avalon catheter just close to the incision. All right, and it's better also to lubricate it with some saline, probably KY. I don't know whether they use KY or not, but so this is how they are doing it here. And it's quite tricky. Sometimes you may get into trouble doing this procedure in the ICU. Then you pass the catheter slow and nice with a little bit of rotationary motion. Make sure that the side hole is going. Now you see the blood which is coming out because you have multiple holes. That's why some blood, once the first hole goes in, the blood will come out from the other holes. Make sure that the side port is towards the patient's face or head. Okay, and now with fluoroscopy, you just adjust your catheter so that the tip of the catheter is just beneath the inferior vena cava. Fix your catheter. Now this applies to these single lumen catheters as well. And then you have to fill up that catheter with blood by removing the plug here, and once blood comes out, clamp the catheter. This is an airless system, so you have to make sure that there's no single air drop is in the system. That's why you use the saline here to take off the air. You'll see it here more clearly. So you put these just beside each other, and with the 50 cc syringe, you push saline inside to take all the air out of the system in that particular fashion. And once you're done that, you take the clamps out. Okay, now you made sure that the catheter is in the right place. You connected both the arterial and the venous catheters, and then you start your ECMO circuit slowly. Don't do it fast. Even if the perfusionist was heavy, tell him just to go slow. And you'll see the dark blood coming out. I hope you see it clearly here. The dark blood is moving this way, and it will go through the circuit and the oxygenator. See it? This is the dark blood, and you'll soon see the oxygenated bright red blood going back to the patient. See? And you could see clearly the difference between the venous deoxygenated blood and the venous oxygenated blood. If you look at the monitor, you'll see that your patient's oxygenation is improving instantly. In fact, within seconds, it will improve to above 90%. And now everybody will clap that you saved, hopefully, somebody's life. Now, you are not done yet. You have to fix that catheter. Now here, they are doing TEE just to confirm that the right atrial return opening is in the right place. You need to do that if you do it correctly. This is the bicaval view of the right atrium, and you see that the flow is going right towards the tricuspid valve. I'll probably explain that more clearly later. So now you have to fix the catheter. There are the different ways of fixing the catheter, and you will see here that the surgeon himself is trying to fix the catheter himself because he doesn't want to waste this effort, and after all the catheter comes out accidentally. So it has to be fixed very, very, very well. So this is the way these people are fixing the catheter. Which is, I think, very reasonable, but I'll show you probably another ways of doing that. So now the catheter is sutured into the skin. It's fixed with multiple long blasters. See the surgeon? He's doing the work himself. I don't know that Dr. Aziz does that. You do it, right? So this is how it ended up like, and you see the cannula is going all the way through in the chest x-ray. Now, I've attended a course in Papworth Hospital in UK, and they're using this very nice tie. It is just like that. So what you do is that you tie the catheter around the patient's neck this way. The catheter will go over here, and here comes the patient's neck. And it's very nice. This is another way of holding the catheter. I don't know how secure this one is. And this is the bicaval view that I've spoken about earlier. So this is the right atrium. This is TEE, by the way. And this is the left atrium. This is the interatrial septum. So where is the SVC? Where is the IVC? What do you think? Which one is this one? IVC. So it's the other way around. This is the SVC. So, you know, things are really turned around here. And there is one clue here. The presence of the Chiari network here, which is a remnant from embryonic life, indicates that this is the SVC. And you see the IVC over here. In fact, you could see the network also in the IVC as well. So, you know, you'll see the catheter going all the way through from the SVC through the RA to the IVC, and the flow should be moving this way. Anyway, so this is the end of my presentation.